Good morning, everybody, and welcome to the launch of State of Care. I'm delighted to see everyone here today. As a publication, State of Care goes well beyond statistics or inspection reports. It tries to give a clear and honest picture of the state of care in England today. It highlights what's working well and where we see innovation and improvement, and it also highlights where we see and have real concern. Importantly, it's there to challenge opinion, discover and understand new trends, and set out how professionals, providers, people who use services can work together to make a difference to the way care is delivered. In the next hour, you'll have the opportunity to hear from the main findings from our chair, Professor Sir Mike Richards, and there'll also be an opportunity to ask questions in the room to our panel. We are live streaming this event, so welcome to those joining elsewhere. Can I ask the panel to introduce themselves, and can I also acknowledge that Bola Abawabi, who's the Chief Inspector of Primary and Community Care, is unfortunately unwell today, so isn't here. But Mike, I wonder if you'd start.
Mike Richards, I'm now the chair of CQC. Some of you will remember me from years ago when I used to be the Chief Inspector of Hospitals, but I left 8 years ago.
Morning everyone, Aaron Chopra, Chief Inspector of Mental Health and Interim Chief Executive.
Good morning, Tolly O'Non, Chief Inspector of Hospitals.
Morning, Chris Badger, Chief Inspector of Adult Social Care and Integrated Care.
Okay, so before we begin, some brief housekeeping points. We're not expecting a fire alarm. Should the alarm go off, we ask you to exit through the signs that are marked. And there's an assembly point in Little George Street, at the corner of Parliament Square. At the end of the session, we'll move to the room next door, if you're able to, where there'll be a series of refreshments to entice you to stay, but also a number of discussion points. And I think the point of State of Care, for me, isn't just that it's a particular message on a particular day, that it should be a jumping off point for a number of conversations around what we need to change, what we need to improve. So there'll be a number of roundtable discussions. On the reverse of your badge, you should see a number. In the best traditions of wedding planning, we're trying to get a range of people into the different tables. So if you can look at the number on your badge, that will reflect a number that's in the room next door. And now I'd like to invite Mike to give an overview of the main findings of State of Care this year.
Thanks, Chris, very much. Good morning, everybody. Before I begin today, I want to acknowledge the news that came out yesterday about Sir Julian Hartley and him stepping down as Chief Executive of CQC. But I also want to acknowledge the anguish and concern that has been expressed by families in Leeds. And clearly, his departure from CQC will be a major loss to us, but I do understand those concerns and reasons, and I think he has made the right decision, but an unselfish decision, because the regulator does need to be seen to be impartial and have very high standards. But Julian can be very proud of what's been achieved in the 11 months that he was CQC's CEO, and you'll hear more about this, but he has refocused the organisation on its purpose, which is to protect people and to improve the quality of care, and he has re-energised our staff to deliver on that purpose. And one of the key things he's done, that's one of his key strengths, is to attract really good people into the organisation. And you'll be hearing from the chief inspectors. We have 4 exceptional chief inspectors. We've also got really exceptional executive directors on top of that. So we will be hearing from them, because one of the things about the State of Care report is it covers all of health and adult social care. So I'd also like to say at the start that I'm very grateful to Wes Streeting for his continuing support of CQC. he set us a challenge. The challenge is that we've got to become the best health and care regulator in the world. And that is actually on page 92 of the 10-year plan, so if you can look it up, but it's there. And then I would also particularly like to welcome the 4 chief inspectors, but I think I need to give particular thanks to Aaron Chopra, whose day job has been as Chief Inspector of Mental Health, but he has very kindly agreed to step up as our interim CEO to give the continuity and stability, and he'll say more about that in a minute. So without more ado, let's get on to the report itself. And if I'm slightly less well prepared than I might normally be, I hope you'll forgive me for this, because this was going to be Julian that was going to have presented it. But no, never mind. I'll do what I can. So let's move on to the next slide. First of all, what is our vision at CQC? It is that everyone should receive safe, effective and compassionate care. We do regulate health and adult social care. We work together with the public, with systems both in health and in adult care, and with the providers of care to protect people. And this business of both promoting and improving quality of care. And we used to have a mantra, and we've probably got that mantra back again, which is we're not an improvement agency per se, but we are an agent for improvement. And that's what we intend to be, and we will get back to being that in a very good way. And what we've done over the last 11 months is we have restated what our values, our purpose, and our behaviours are. And importantly, in addition to that, what our commitments are, both to our own staff, but also to the wider world that we regulate. And we want to be held to account for those behaviours and those commitments. So that is a major first step in recovery of CQC. But now let's turn to the state of health and care outside CQC, if you like, in England. So what we're saying here, and I think this is the big headline, if you like, the whole system remains fragmented and under severe strain. And that is in the context of moving the major shift from hospital to community care, which is one of the 3 shifts in the government's 10-year plan. And we support those 3 shifts, but what we want to do is highlight the importance, particularly today, highlight the importance of the shift to the community, because we believe that will be absolutely vital for improving care. But we're also saying that without more support to help community services, the delivery of that vision is going to be very difficult. And there's actually the risk then that care quality will be eroded. And if we look at community services, it doesn't matter whether we're talking about community health, community mental health, dental services, all of those showing the strain that there are. We'll come back to some of those points as we go through. Another point that we want to highlight, which I think is well understood already, but is about the long-standing inequalities. And if we don't do something about that, we will actually increase those problems, so we need targeted action. And again, there are some specific groups that are more likely to have difficulty navigating services. So, for example, people in deprived communities have more difficulty in accessing services. And in terms of maternity services, the Embrace data actually show us that black women have a higher maternal death rate than others, but considerably higher. So we would like to see more focus on an investment in community care, and that is all sorts of community care, to make that shift possible. And all the talk that there is about neighbourhoods, we now need to make those become a reality. And we, as CQC, need to learn how to inspect and assess the new emerging neighbourhood services as they come on stream. We have seen some really encouraging evidence of innovation, but it's pockets. And we try to gather some of those examples in the report and in the full report. But we need now to see those actually mushrooming so that they're across the whole country. And then it would be remiss of me not to say we do continue to say we need a long-term sustainable funding solution for adult social care. I'll come back to that in a moment. So let's move on to the next slide, but those are the headlines. So let's then think about mental health in particular. And again, what we're seeing is this increase, the pressure. A factor that goes across the sectors is the increasing demand for services, even in the last year. And that's certainly seen in terms of mental health services, number of increasing referrals to mental health services, steadily increasing. And that partly may be a post-pandemic effect, but there are probably other reasons as well. And in response to that, we have already begun a comprehensive inspection programme of community mental health services with their crisis services, so that because we know that there are problems there, and we want to do that as a full round of inspections. What we're already hearing from providers is about the lack of investment in those services, and that making it difficult to attract retained staff with the right skills and to deliver good care. And then this is a really important point at the end. If we don't get that timely care, what happens is that people end up in crisis. And I think that, again, is well demonstrated in mental health, but is probably also true in other sectors as well. And so the number of, in terms of mental health, the number of urgent and very urgent referrals to crisis services has gone up markedly. Next slide. So if we turn now to adult social care, again, same story. In adult social care, demand is continuing to rise. And that's partly demographic, but it's not solely demographic. Actually, the demand of people, of working age adults, has risen really markedly in the last couple of years. And we know that if you look overall at the proportion of people over 65 who are receiving adult social care, over a 20-year period, that has decreased markedly. And we still have a problem of staff vacancies in adult social care, and that remains wider than that in the rest of the job market. And we've got particular problems with the home care sector, which with vacancy rates that double those in care homes. We're worried about the end of the new care worker visa, and that's likely to put further pressure on recruitment. So that's another worry, which is why we need more than ever a sector-wide workforce strategy. And obviously fair pay agreement. If we want to help people to stay in their own homes longer, which a lot of people want to be able to do, we need more community services. Back to the point I was making earlier about community services, that includes adult social care. And one of the things that I really think has moved forward from a CQC perspective over the last year or so is our local authority assessments. And we're doing a complete round of all local authorities, which is the first time that we've had the power to do that. And I think that is giving us a great deal of insight effectively into how adult social care services are commissioned. And there are some good things there. We are actually seeing that the number of needs assessments that's been done is going up. That's good news. But actually, as soon as you do the needs assessment, you find that they do have needs, and therefore you need to be able to meet those needs. Shall we move on to the hospital sector? No surprises here, I think. We've got emergent and emergency care services remaining under huge pressure, long waits in emergency departments, so-called corridor care. But I think one of the main points there is the number who are waiting more than 12 hours still going up. And partly what is the problem with it? Is the department purely in the A&E department? No. It is also that one can't get them into the rest of the hospital because hospital discharges persist. And this is, I think, really quite a stark fact that just earlier this year, almost 6 in 10 patients who were medically ready for discharge actually experienced some form of delay. And quite a lot of those delays were actually about getting access to rehab and reablement services. And that, of course, the impact of that is it means there's a number of beds and it all blocks up down the line. And with that, if one doesn't have the right care when people get home, what happens is that there are more people being readmitted as emergencies. And that, again, back to the inequalities factor, that is more common in those living in deprived areas. Moving on from that to primary and community care. What have we seen here? We are training more GPs, but the actual total number of GPs has not increased in the same way. That will take time to come through. So there are still huge capacity challenges within the primary care services. And we find that we conduct a GP patient survey every year, and that is access to GP appointments does remain a challenge. There may be some improvements there, but there is a big challenge. And if they don't get help from their GP when they need it, they may go to a service. And again, our surveys have shown that is the case. And then something I really do want to emphasise is the point about district nursing services, where if you take a 14-year look at this, the number of district nurses has fallen by 50%. So it is really quite a marked drop there. And again, we feel that is going to threaten the success of what we all want to see, which is the 3 shifts working, and particularly that shift to the community. Moving on from that, we go into next steps. What we think that state of care is all about is it helps to shape what we are going to be doing in the coming year. Where are the challenges? And we want your feedback on that. Just turning back to CQC for a moment, many of you will know that we have a consultation that's ongoing now on how we assess and rate providers. People will know that we had moved to having a single assessment framework, but our view is that hasn't worked as well as it should, so we want to get back to something nearer to where we were before, but actually want to move forward as well. It's not just about going backwards, it is about how can we do this better in the future. And one of the things that came through when I did my review of CQC this time last year was the need to redefine what does good look like. That message was coming to me strongly from providers, hospital providers and adult social care providers saying, tell us what good looks like in your view, and that's what we will then aim for. So that work, and the chief inspectors are going to be leading a lot of that work. Along with that, what we're doing is we are moving back into sector-specific teams. And there will be 4 teams now rather than 3, which was what it was in my previous days. So as well as Tolly doing hospitals, Aaron, when he's back to his day job, will be doing mental health. And I welcome the fact that we now do have a chief inspector for mental health, as well as adult social care and primary and community care. And I know that Bola is very disappointed that she can't be here today. And you will all be aware that we've had major problems with the IT system, and we are in the process of rebuilding that, the so-called regulatory platform and the provider portal. I know how much concern and consternation that gives, both internally and externally, both to our own staff and to providers. That work is in hand. it inevitably is going to take time, and we inevitably within that we have to prioritise some things ahead of others. But we are on the case for that. And then one new thing to announce today, that because of the concerns about maternity services across the country, this is not just in one place, but across the country, I am commissioning an internal review, but an independent review, of how we as CQC inspect and rate maternity services. And along with that, we're looking at MNSI, which also comes within CQC. So those are all things that we are doing to try and improve how we go about our duties and functions. Next slide. So, you've all got the summary of the report, but if you want the full report, that is the QR code, and you can download it from there. But now, I don't know if Chris, you want to introduce the rest, or just to go straight to Aaron?
Yeah, straight to Aaron.
I'm really pleased that Aaron has stepped up to the plate, but he will now sort of introduce yourself.
Good morning all, thank you for joining us. It's been brilliant to have the chance to have a catch up with some of you over coffee this morning, and I'm really grateful for your support, and I've noticed that many of you were asking questions about how we're doing as an organisation, and I just wanted to reflect on and recognise the emotions that many of my colleagues across the organisation are experiencing following Sir Julian's news. Difficult situation, and we fully respect his decision. Over the last couple of days, I've been, as you'd imagine, I've been speaking to my colleagues, and one of the things that I've been really struck by is the resilience that many of my colleagues have described, as well as experiencing those emotions, that sense of stability that they want and that they're providing to their teams, the compassion that they're showing for one another through this difficult period, and our real strong sense of purpose as a regulator. That's coming through to me really strongly, and I've mentioned that to some of you over coffee this morning, as that's how we're feeling. Reflecting on that a little bit further as to where that resilience is coming from, where that strong sense of purpose is coming from, I have to say I think this is in no small part due to the leadership of Sir Julian and the momentum that he has given to this organisation over the time that he's been with us, the platform that he's brought us to. So I really want to acknowledge and thank him for the exemplary leadership that he's shown to our organisation, which has really shown how we have that stability, that compassion for each other, and that clear sense of purpose as a regulator. I also want to say thank you to Sir Mike, to our non-exec directors and my exec colleagues and colleagues across the organisation who are also committed to that stability, that sense of purpose. And I also want to say a thanks to Chris Sakiti. So whilst I'll be in the interim role, I'm really grateful that Chris Sakiti will be supporting our work with the mental health sector to protect patients, make sure that care is great, and support providers to innovate and improve. So it's a core purpose, so thanks to Chris. As we launch State of Care today, it really does reflect, Mike's shared our summary of what we're seeing across the sector, but it really does reflect the work and dedication of so many of my colleagues across the CQC who have really kind of, to fulfill our role as a regulator, we've drawn from the inspection activity we do, the Mental Health Act review work we do, the surveys that we put out there. We've worked with our stakeholders to bring together that picture of where we're at. And I wanted to say thank you to all my colleagues whose work is reflected in what we're presenting today. I'm really looking forward to discussing what Sir Mike has set out as a summary with you. I'm really looking forward to hearing your thoughts and comments. Thanks all very much.
Okay, so we are now open for questions. There are two roving mics that shall be coming round So Bren's always first. If anybody's done these things for years, Bren always beats anybody else slightly to the first question. Just so I can ask if you could give your name and the organisation you represent when you give your question.
Thanks, Chris. I'm Bren. I volunteer in the community, so I don't come here from an organisation. I also sit on Care Quality Commission's National External Strategic Advisory Group, both of which I'm hugely proud of. So in terms of some of the things we talked about, my personal view is we are where we are. Let's look forward and let's go forward that purpose. That's where but actually, Lord, let's measure where we are as well along that journey. So my question, comment is how can we get better, and I use the word better, at actually really taking forward the measures of inequity based upon the people and communities we serve. Most of my meetings are in front rooms of housing, so I was proudly invited by my friends Ruby and Simi from the Bangladeshi community to look at planning an event. And I asked them, I said, look, I'm coming to this event. What matters to you? What would be really important to share? And I think they said consistency. You know, as we're delivering services in the hospital or in the GP practice, care homes, etc. And they gave me a trail where some of their families had actually used a lot of those services, and they were unequal, inconsistent, and actually caused a lot of anxiety. So something about how we better do that, but also how do we measure that from the views, the eyes, the ears, and the experiences of the people most in need, but all people. Thank you, Chris, and thanks to everyone.
Thank you, Bren. If I may, panel, I'll start the answer to that, but I'm happy for other colleagues to join in. It's a really important question, Bren, and partly it's important because state of care at one level is a national conversation about how health and care is delivered. But if we look at it just as a national picture, we miss the variation that some people, how some people experience care. So for me, there are a couple of really important things. Looking beneath the national data to people's real experience of care. Some of the things that we've done, which I'm proud of, but we need to continue doing and do more of, is how do we listen to the voice of people in the place that they are? So don't ask them to come to us, we go to them. How do we work with organisations that represent people who use services, and in fact just represent them in different guises? We've both been to Gloucester to talk to groups that are not health or care groups, they're just groups of people, but they give us their experience of care, particularly around access to care, and also about their experience about the quality. So I think there's probably three things for me. There's making sure that we continue to look for the variation and don't just look to try and present a national picture. There's really focusing on building trust with people who use services so that we can hear their voice more effectively. And then finally for me, it's about how we use that voice to try and build change at a local level in the system. Part of the issue for me around ICB's, local authorities' neighbourhood care is how do we make sure that they're the right response to each area, because the right response is probably different in different areas, and we have a tendency to sort of look for homogenous answers. So I think for me, building that trust, making sure that we can respond to that, and making sure that we can work with organisations to build a representative improvement for their area is critical. I don't know if my colleagues have anything to add to that.
Shall I start and then I'll hand over? To a certain extent, both the Health Service and CQC have been moderately good at measuring inequalities. What we haven't actually done is reduce them. But one thing I think CQC can do is to find those innovative examples where it has worked, where people have, often at a local level, really done things that can, because then we want to share best practice on that. It's a shame that Bola isn't with us today because, as people will know, she comes to us from NHS England, where she's had a particular emphasis on reducing inequalities, and the core 20+5 is Bola's, as far as I'm aware. So she will, don't you worry, she will be keeping that focus going. But I'll hand over to others to say for their own bits or any general bits.
Yeah, thanks, Mike. Thanks, Bran. Excellent starting question. That inequality piece is one of the most important aspects of care. If we can tackle inequalities, will actually kind of make things better for everyone. I wanted to say a little bit about the mental health sector. I mean, we've known for ages now that there is inequity and there's an overrepresentation of people from minoritised ethnic communities who are detained under the Mental Health Act, subject to more coercive sort of care. That data has been widely known for quite a while. When you start interrogating as to what's underlying that, that's when you see the system join up. And one of the things in our State of Care report for this year, and I'm sure Bola would have spoken about it, is the different access that people from different communities have to primary care, to seeing your GP. If we don't get that first bit of the system right, then you start seeing problems further downstream. Having said that, I am really encouraged, and I know NHS Confed, Rebecca Gray and I were having a conversation about this earlier. The patient carer race equality framework that's come in from April of this year offers an opportunity for mental health trusts to make sure that they are working very closely with some of the communities who experience the most disadvantage. What we will be doing as a regulator is embedding that approach into our assessment framework and how we ask the right sort of questions that will encourage innovation, improvement in that space. So that's a very specific example in mental health, but it shows how we can use our regulatory levers to help correct some of that. Thank you.
Right. No? Okay, we can move to the next question. Yeah.
Thank you. I'm Emily Holtzhausen. I'm Director of Policy at Carers UK. And I just wanted to say what a very honest report this was and really chimed with some of the evidence that families, unpaid carers have given us that we published earlier this week. When care falls short, it's very often, I mean, obviously people go without, but it's very often families who have to do more. 52% of carers were doing more. And of course, this impacts enormously. People have to give up work. They experience greater health inequalities. So I just wondered if you would, this also impacts on the wider economy, of course, for business. And I wondered whether the panel would like to give a reflection on how important reducing these inequalities, improving systems is on our wider economy as well, improving the lives of carers, obviously.
Again, if I'll start, but I'm happy to go to you, Chris. Do you want to go first, Chris?
Yeah. Thanks, Emily. So, I mean, firstly, I think the other thing I'd bring out on experience of unpaid carers would be our emerging work on local authority assessments has shown quite a mixed picture in terms of the effectiveness of support for carers. Some really good practice in other areas where councils acknowledge they need to do more, partly reflecting just the increased amount of support unpaid carers are delivering. The councils recognising the need to catch up, and when we go back to local authorities, a big focus will be testing how far that's gone, and particularly in relation to work with the voluntary community sector, number one. Number two, I think the economic activity is twofold. One is that, just the size of the adult care workforce, and I think Skills for Care's comments around how much economic activity that delivers is helpful. 1.7 million people employed. And I think changing the narrative from social care somehow being a kind of drag on society or a burden to something that, A, delivers economic activity and provides an infrastructure to support a reduction in worklessness. I think particularly around all parties doing much more around how they support people, working age adults, into employment. We've seen that being the biggest single increase in people accessing adult care. That's a really significant increase from pre-COVID, 14% increase in demand with that cohort of working age adults. We know how important a job is for individuals in terms of their connectivity with the community and for the wider economy. So I think it's a call to action for all of us across health and social care to keep that at the forefront of our minds.
Thank you.
Hi, thanks, Chris. William Pett from Health Watch England. There's been quite a sombre tone this morning. Can you still hear me? Is this working? There's been quite a sombre tone this morning, and I can understand why, given what you've presented in the report and given the news this week. But I'm just going to attempt to try and inject at least a dose of optimism this morning. So, Mike, we've had conversations about patient experience of community diagnostic centres, for example, which is remarkably high. So we can do it well. And I'm just wondering if the panel could reflect on where are the other shoots of optimism across the health and care system? Because, yes, there's lots of bad, but I'm interested in hearing about some of the good as well.
Good. Do you want to start?
Thank you for that, and I think we do need to, obviously, as we've set out, the systems are under huge strain, but there are lots of examples, and some of them are in the full report. You have to get beyond the summary to find examples of practice. You mentioned community diagnostic centres, and that was something that I was very closely involved with in a previous role when I was working particularly with NHS England. We needed more diagnostic capacity. The big question was, should we provide that in the hospital sector, or should we try and provide it closer to people's homes? Most hospitals that I know have visited, and I have visited an awful lot in my time, they are jam-packed full. Putting an extra CT scanner in isn't easy. You usually have to get a crane and lift it over one building and into another. And anyway, there isn't any parking. So why not put it into the community? We've now got 170 community diagnostic centres, and as you say, one of the things we've built into that programme is actually asking people about their experience in a fairly structured way, and it's coming back really very high. Now, I think that's a starting point for community services. You could say those are neighbourhood services. Now, how many we need in the end, we can debate, but lots more like that, and not just in diagnostics, but in therapies. Don't always need to go up to a hospital for the treatments either, and sometimes those can be done side by side. So I think that's a model, but we can build on that and have much more in terms of neighbourhood health services. Tolly, you might want to say something about that.
All right, thank you very much. And thank you for giving us the opportunity for optimism. I appreciate that. If I might then, we'll just flip around what we say right at the start. So we're highlighting fragmentation in care, but actually, as you've said, there's also examples of fantastic integration and join-up of the pathway for patients and service users. So an individual's care pathway can run across all the sectors that we regulate, and rightly, we are regulating to ensure that patients are not falling between gaps. But in so many instances, individuals get great care from their communities through the hospital sector, discharged back out into community, supported by community mental health or by social care. And where that works well in those ICSs, there's an opportunity for everyone to learn. We're really conscious within CQC that we're going back into our sectors, and we need to get all the benefits of our sector-specific expertise. But actually, what we can't do internally is start developing silos. So the four of us and our corporate colleagues, and with our board, we are so conscious of that, and we'll constantly remind each other and need our stakeholders to keep reminding us of that as well. Thank you.
Shall I go next? Okay. Thank you for asking us a question about what makes us optimistic and for kind of that tonal shift. Two things I want to say. When I've been out with my team on inspections and on mental health act visits, I've been struck by the compassion of so many staff and providers. It's really humbling to see the work they do, often under challenging circumstances. That makes me optimistic. On a specific policy measure in mental health, it's about neighbourhoods. The neighbourhood 24/7 model, there's 6 pilots at the moment in England, but there's other associated sites, and it really does provide a mechanism, particularly for people with more severe mental illness, to get help when they need it, without some of the bureaucracy that comes with getting appointments. I find that very optimistic, and I've heard from all 6 of the sites. They're all doing things slightly differently, but it is great to see some of the innovation that's taking place there. Thanks.
Thank you. Yeah. Okay, next question. I'll come to...
Thank you. I'm going to embarrass you, Christopher. Thank you so much for this time last year. I ended up in hospital having to have an emergency transfusion. There was issues, but this man got his team to sort out some of them. I got a patient accusing me of being abused. He sorted it out where I saw the chief nurse. So that's leadership. and you guys deserve a medal because this week has challenged most organisations, but you've come out fighting, and the staff deserve a credit to put this on today and come out fighting and show everybody's, you know, still wanting to do the right thing is the best thing. So that's one thing. Second, I think we ought to thank the organising people who have looked after us so well. I know it doesn't go often, but I think it needs to be important because these things aren't something you can knock up on the back of a backpack. But also to you guys as well, because if we don't do it, but the real issue I want to raise is what work are we going to have? I've not had a chance to look at the state of care report because it pinged on my phone about 6 o'clock this morning on the train, so I've not had a chance to look at it. But in terms of the mental health bill, a lot of people with learning disability and autism are confused at the moment. The legal profession not, because it all got controlled from Parliament about whether people with learning disability and autism were part of the... Yeah. What is CQC going to do it? Bearing in mind the mental health bit. Because if we don't get this right, we could have another, Mr. B or whatever he was called in Strasbourg. But also, I'm glad we're going back to the previous chief exec, Andrew Sutcliffe, where we're talking about, if you like, what would mum or what would I like as a service? Because if we don't get that right, and I have one more plea, please get a chief exec that gets the management stuff right, but also the service user. Because if you don't get the service user right, you're not going to be friends with the service user, and the service user is your key ally to making these things work.
Yeah, thank you, Sam. Important comments.
I'm just a bit disappointed that sometimes the top at CQC doesn't quite get the language of being able to change it for different audiences, because if you don't, then it doesn't work.
Yeah.
And I'm sorry to be brutally honest.
No, in really important comments, those, Simon. Aaron, I wonder if you want to...
So we're going to go Chris Badger and then myself.
Yes, okay.
I think it's a really good point around the changes to the Mental Health Act, and that's a really good example of where, certainly in CQC and of course across the health and social care system, working together to understand those implications, particularly for people with a learning disability and autism, is going to be important. That links to a theme from me that I'm thinking through for the next 1 to 2 years, is also, I think, looking at the different types of commissioning across health and social care, and I think quite a variation in the quality of that commissioning to support particularly really effective community services, and that's something we want to look at, but we need to do that across health and social care, and that will be a continual theme. And your point around language, around senior leaders, I think that's absolutely right to hold us to account on that, and I think crucially, we are all more energised when we go out and about and look at services in person. That's what gets us up in the morning. We do 2 things at CQC. We look at a lot of graphs and we look at a lot of services, and it's much more energising doing the latter than the former, and we need to keep doing that, and we'll make sure that we do.
Thank you. Thank you for your question. I think the aims from the Mental Health Act, the new Mental Health Act, will only be realised if there is a shifting of resources to the community for people with learning disability and autism, and that provision is created. And that's going to be key to realising what that particular aspect that you were speaking to around learning disability and autism in the Act. I am generally really excited about some of the provisions that are coming through with the Act, the advanced choice documents, which will give a real opportunity for people with mental illness, people who use services, their carers, to have a voice at times when they may lack the ability due to illness to have that voice. So I'm really encouraged by the advanced choice documents. But on the learning disability and autism bit, it fits very much with the direction of the 10-year plan and that shift to community, but it is really an opportunity to bring those things together.
Thank you. Next question. Okay. Centre first, then we'll go to the end. Yeah.
Thank you. I'm Jackie Sherlock from the Challenging Behaviour Foundation. We focus specifically on children, young people and adults with severe learning disabilities. And sorry, I know you were injecting some optimism, but what we've been hearing from the families we support recently very much chimes with the kind of picture you painted at the start, Mike, in terms of fragmentation and increased crisis and so on. And for people with the most complex needs, their pathway will always cross all the different services you inspect. But what we've been finding is that more and more people are unable to find support for their relatives, so they might be looking at many tens of providers, but if their relative has both behaviours that challenge and complex health needs, and perhaps is getting older, or any kind of mix of things going on, there are people who can support one of those elements but not others. And actually, as was mentioned by my colleague behind, that often leaves families with no support whatsoever. And it would just be helpful to kind of have the panel's reflections on how things are looking for people with the most complex needs, and how we might take those opportunities that are coming in terms of change to really get it right for those people, because if we do, then that's going to make a difference to everybody.
Aaron, do you want to talk this?
Yeah, and 3 months ago, I was our Director of Adult Social Care, and the kind of scenarios you painted were the ones that, in a sense, caused me most concern in securing that support in the right way that reflected those needs. And I think in terms of that point about commissioning and securing the right support, we need to be in a position where collectively we're trying to help providers, help of any variety, develop their services so that we're commissioning services that are going to be fit for the next 5 to 10 years, not on models from 5 to 10 years ago. Again, I think the pattern of how we commission that is varied, and we need to understand that variability. I think the changes around the Mental Health Act will put a lot of that into sharp focus. I think we need to use that as a fillip to really take that on. And I'm also concerned about the financial fragility of those markets. Of all the care markets we look at, learning disability in terms of the market oversight data we get has the lowest profit margin, has seen the most significant impact of things like the national insurance changes and so forth, and therefore that gives me most concern in the next 1 to 2 years in terms of provider stability. And I think that's the most fragile care market we have. However, we do see places that are really looking to commission across health and social care. It's really important that the changes to ICBs don't get in the way of really thoughtful joint commissioning in that area. And I think that's something that we all need to take forward to make sure we protect that focus over the coming year.
Do you want to add into that?
Thanks, Chris. Jackie, just to add to that what we sometimes see for those people with the most complex needs around with learning disabilities, that because of what the situation you described and that lack of support that's available, they will often end up in some of the most restrictive environments, and that can then lead to conditions such as segregation, seclusion. I wanted to reflect a little, and we've mentioned it in our report, in the work that we've been doing around the ICETR programme, and looking at those situations where people are with complex needs are subject to that sort of intervention, where they are effectively not getting human contact. That programme that the CQC has been running for a bit of time now has helped. I think we've done about 71 ICTR reviews, and 19 people have moved out of situations where they've been in long-term segregation to being back in kind of communal settings, in some cases to home. So I recognise the question, and I recognise the impact it can have, and I wanted to share some of the work that we've been doing over the last year, which is reflected in State of Care. Thank you.
Thank you. Jim, go. Yeah, Jake first, and go that side.
Thank you. I'm Jacob from National Voices. My question is about integrated care. Tolly, you touched on sort of the informal stuff CQC can do in terms of making sure that you don't create silos within the different chief inspector roles, and that's great to hear. But can the panel comment on CQC's future role on integrated care, looking at ICBs and really pushing out the message to providers that actually it's the gaps between services that really, that's where poor care really happens. And it would be good to know what the panel's position is on the formal role CQC has on integrated care.
Do you want to go first?
Yeah, if I can come in on that. So the model isn't yet fully defined. So it's made us aware that regulation of that model also is not fully defined, but it's obviously going to span our sectors. So Bola and Chris in particular are doing, you know, a lot of work now, beginning to look into that. I think we've got to think about the structure of the provision, because the way that the care is provided, the lead provider almost, will also make it clearer for us on how that's regulated. But I think it is issues, as you say. Will the provider come from primary community, or the provider come from secondary? Either model could work in a particular ICS. For those commissioners of care, as long as their structures are clear and their culture and their relationships are good, they can make it work. But how do we regulate in a way that facilitates that as well and ensures that it is seamless? Otherwise, it's the patients and service users who pay the price of it not being by falling in the gaps. So absolutely valid point you raise, and something that we are looking at now. We've had some informal discussion with colleagues at NHS England about that, but it's a really important point. Thank you.
Chris Jones.
Yeah, I mean, and on that, I think where I'm most interested in integrated care is what does that feel like in the neighbourhood to someone being supported, rather than anything sort of more strategic or abstract. That's going to be where the most opportunities for progress are, but some of the biggest risks too. And I think crucially for CQC, we probably want to develop that approach as new models develop. What we need to be is a permissive regulator, not one that gets in the way of that. And sometimes if we don't adapt, then the fact that we regulate by provider or by organisation could inadvertently restrict or constrain good practice, and we don't want to do that. It's absolutely opposite to what we want to do. So I think we need to go in with a safe but permissive approach that looks to recognise collaboration. And then when individual organisations are regulated, if they're not delivering or working in partnership, that's absolutely part of our judgment around their effectiveness, if this is a new way of working. So we need to look at that in both angles.
Thanks. Next question.
Hi, my name's James Booth. I'm a GP and I'm here from the BMA's GP committee. My question's about GP inspections, and we hear a lot from our members about how demoralising the inspection process can feel when you are a small team, and a lot of practices are, of course, very small teams under intense pressure. And we hear a lot from GPs who reflect that having the full experience of their care reduced down to just a word or two in a single word assessment can be one of the most stressful parts of that experience. We would like to ask whether there is work being done in the consultation in the way that Ofsted had to move away from that very, very brief summative description of the inspection around a much wider narrative. And I think it does contribute to the vulnerability of GPs and their teams, partly also because we have a lot of practices who have had reports that have required improvement, or and particularly requires improvement reports where they are stuck with that rating because they're waiting to be re-inspected, and they are desperate to demonstrate that they have rectified what are often quite small things in the care they deliver, and can't, and still have that rating hanging around their neck. So that's the other thing we would like to ask for, is speedier re-inspection so people can demonstrate the good work that they've put in to remedy problems.
Mike, I'll come to you first.
Several points to make on that, and I'm sure if Bola Oluwabi was here, she would also want to make comments about that. I think the speed of re-inspection, this doesn't only apply in primary care, by the way, it applies across the board. We all know we haven't been doing the volume of inspections, or indeed, therefore, the quality of inspections that we need to be doing. And that is part of our programme, is to get back to doing those. And particularly to be able to go back to those that are inadequate, to go back to them first, but then also to go back to those that requires improvement. And that certainly, we hear that frequently also in the adult social care arena, where if they've got a requires improvement, they can't necessarily get the business in, if you like, that they would otherwise. So we recognise the importance of that. In terms of ratings, a couple of things on that. First off, actually, I think a lot of patients, the public, do want to be able to have a brief assessment. Now, it's a single word rating isn't the whole story, obviously, but that then comes back to what I mentioned briefly in my introductory comments, which is about redefining what good looks like. And that is going to be true for primary care every bit as much as it is in any other sector. So we want, and this is not just what CQC determines is good, we want to work with people in each sector to define that, so people know what we're going to be looking for, and actually they can aspire to it first, so that there are no surprises. They know what it is we're looking for, and I think that across sectors. And so I think ratings are going to stay with us, but what we've got to do is do it better, do it faster, as you say, but do it with people so that people know what we're aiming for.
Thank you. So I'm Nick Presmeg. I'm the Exec Director of Adults for Essex County Council, but I'm also here as a policy trustee for ADAS, which is the Association of Directors of Adult Social Services. It's actually in a similar vein. In our provider market, we've got, frankly, unacceptable delays in terms of inspection, regulation, and rating. You've already touched on the commercial impact that can have. Of course, it also has an impact on an individual's ability to choose and exercise control from a position of knowledge. It cuts straight into my statutory responsibilities to commission good services within the Care Act, and of course it's a failure of duty on your part. However, I don't see where your resources are going to come from to improve the situation, so I wonder what your thinking is in terms of what we can do collaboratively to create some resource in that space that actually moves on what's becoming a little bit of a crisis situation in the social care market.
Chris, do you want to start?
Yeah, thanks Nick. And my number one imperative operationally is to carry out, in the adult social care sector, is to carry out more inspections. That's what our teams want to do. That's what providers want. That's what the government wants. There's no debate about it, and there's been a lot of barriers in place for those teams to be able to do that. I think we've made some immediate changes to help that. It's really important as well to think, what level of resource have we got at the minute, and how do we prioritise what we've got to manage risk? And at the minute, we're responding, and we're quite reactive in terms of how we approach inspections. So we're responding to information of concern and safeguarding. Where I've already asked the team to look at, and we'll be coming out with a proposal to the sector soon, and we talked with colleagues around this last week, is actually we're responding to known risk, but actually there's significant risk in providers we haven't crossed a threshold for. Either a risk that they've improved and they're not getting the rating that they should, or conversely, they're good or outstanding, and that's impacting people's choice of a care provider, but actually care's deteriorated significantly. So that's a risk that we just don't know about, but it's a risk. So I want us to refocus our level of prioritisation to focus on that as well, which impacts on the age rating. We need to do some work to look at what the regulatory activity is across our, in adult care, 30,000 care providers. What would it take to inspect every setting every 3 years? What would that look like? And do a productivity analysis. And then we're going to need to understand what's the level of resource that we need to do that. As anyone in the public sector will attest, it's unlikely that we'll ever have as much as we want. I think then crucial to that will be how can we share intelligence with local authorities on, for example, PAMS assessments, use of artificial intelligence on insight that we gather. And I think for providers, they'd rather we were collaborating with local authorities rather than having someone go in and asking pretty similar but slightly different questions together. So again, I think there is an area there where we can all benefit. And my priority will be looking at getting a number of those to work quickly to try and solve some of those issues.
Thanks. Any other questions? Yes. I'll come to you next.
Thanks very much. Jackie O'Sullivan from MENCAP. Firstly, please do carry on speaking truth to power. I think this is a really fantastic report, and it's a real mine of useful data and information that we can draw on to inform our policy making and our influencing. So it's really great. I'm also really interested in your findings about the Learning Disability Register and also annual health checks, because we know that these are so important. We know that they have actually led, things like this have led to actually life expectancy improving for people with a learning disability, and yet the register's now not on the QOF, the target for annual health checks has been dropped. So any more that you can do to really drive home the importance of these measures would be much appreciated.
Don't you want to come in on that?
Yeah, I think it's beholden on us as an independent regulator, perhaps more than any other group that we overall sort of oversee, to keep lobbying very clearly for the importance of services, support, resources for people with learning disability and autism. If you read the annual leader reports from local authorities or the national one, the starkness of health inequalities, albeit have improved slightly, should never be read without a really deep reflection of how profound and enduring they are. And that's a responsibility of every single person in the health and social care system to address. I think it's really important in adult social care that the Casey Commission really understands learning disability and autism, and that sometimes the national narrative, I think, on social care can get a little bit too dominated by who pays for older people's care, rather than the quality of support for people with learning disability and autism. We and others in this room have a leadership responsibility to keep that higher on the government's agenda.
Yeah, I think that's right. And thank you for your general comments about the report. I think there's a general point for us about trying to understand what works well and why it works. I think that's the best way to encourage policymakers and local services to act differently. So thank you. Comment, Commissioner.
Yes, good morning everyone. Karen Fuller from Oxfordshire on the DAS there. So I've got a bit of a reflection and a question, if that's okay. So I think today the report really does make it clear that sustainable funding won't transform community services alone. And I think commissioners are being asked to do things differently, to innovate, collaborate and invest in models that are prevention and person-centred. But they're often constrained by short-term funding and challenges around what we can do. So I think the question for me is, we've referenced a couple of times about commissioning, which the landscape does absolutely need to change. I think positively in supporting people to live in their own communities is absolutely the right thing to do. But how can we ensure that funding models support innovation rather than reinforce the status quo? And it would be good to hear a reflection from CQC as to what you think this could look like and how it fits into how you're changing as an organisation and how you can accelerate, and we can do that collaboratively with you.
Chris, do you want to go first?
Yeah, well, look, we've long held a long-term sustainable funding solution for in particular adult care is important. I think that there's two elements to that. One is the overall, like the quantum, but also there's the kind of how, what's the time frame that certainly local authorities, for example, have got certainty over funding levels. And I was speaking to some care providers who are here actually from Leeds in one of my first weeks. And in terms of developing those thoughtful models that are commissioned, longer term contracts with providers, just at the granular level, helps them develop their workforce, plans and innovative. And I think in a sense gives us much more room to be ambitious and innovative in what we do. But to do that, there needs to be a medium-term position on financing. That needs to then be passed on in terms of good commissioning practice to longer-term contracts with providers around, for example, intermediate care, which we see is making a big difference, but is also the single biggest reason for delayed hospital discharge. If you speak to a provider and they're asked to commission some intermediate care about this time of year, ready for next month's winter pressure, it doesn't tend to work. But if you say, how can we do that for the next 3 years, because the winter will look pretty similar each time as we go on, then actually the workforce, the joint working can happen. So there's some stuff I think systems can do now with a bit of bravery, but that can be expedited if that funding solution includes a much longer term certainty for all concerned about the money.
Thank you. We've got
Chris,
time for probably one or two more questions.
Chris.
Sorry, Tolly, do you want to come in?
Sorry, yeah, if I might just add to that as well. I think the report does address, doesn't it, the fact that so much funding sits in the acute sector and not in the community. And the metrics all come, not all, but the metrics predominantly come from the acute sector as well. And so there isn't the same focus on community because the data isn't there about supporting it. But almost sort of common sense, we would understand that community care is going to be more cost effective than in the acute sector. However, we're not in a position to be able to shift it out. Providers can't do that, commissioners can't do that. But it's recognising, actually, maybe getting over that hump of being able to move some of the funding out. Because a lot of the care that takes place in the acute sector, as we've seen from the report, shouldn't be there. It's not in the interest of the patients, is it, to be there? And the providers in any of those sectors know that and are frustrated by it. So it's how the collaborative work happens to enable that. And within a lot of acute sectors, I think the report references also the infrastructure that's hampering those teams. You know, investing in that, improving the opportunities from technology and so on to help move that care. I realise I'm condensing an extremely complex topic and trying a couple of sentences, but I think that's probably the principles of what the report's saying. And I think we all acknowledge the difficulty in making it happen. A colleague earlier, though, did reference as well, we've had a few references to the economic benefits around this. You know, as a nation, if we get more of our workforce healthy and economically active, then that, you know, that's good for everyone. Thank you.
Thank you, Tolly. Sorry, a question. We've got time for one more after that, and then that's probably it.
Hi, Rebecca Gray from the NHS Confederation. I'm really welcome the focus on weights in community and mental health services in the report. I suppose it's another question that's really about how does what you're doing connect to other parts of national policy. So there's a preparation at the moment for a national workforce plan, a revised national workforce plan. And I'm really conscious that a lot of what you're pointing at are issues that relate to not necessarily just lack of workforce, but maybe workforce being in the wrong place or workforce working in slightly, not necessarily the ways that we're going to need them to work in the future. And I'm very conscious of that. Another mental health point, but in the mental health sector around, often we think about workforce in terms of just the numbers of doctors and nurses, and particularly in areas where interest in working in some of those sectors declined. How do we think differently, and more particularly around access to trained people who are trained in evidence-based psychological therapies? I know Aaron, you'll be concerned about the numbers of people who are approved mental health act professionals and gaps there, and all the problems that can cause. So I suppose it's just asking really about how does what you're presenting today flow through to a very current piece of work influencing workforce planning for the next few years.
Thank you. Do you want to go first, Mark?
Yeah, shall I go first, and then Chris, if you wanted to add anything. Rebecca, I totally recognise the point that you're making in the question. Can I if I just illustrate that with some statistics, which I found, which we've referenced a 15% increase in the number of referrals from primary care to secondary care mental health services just in this last year. So 15% increase in the number of people who are seeking secondary care mental health support. Previous years, just to put that in context, 6%, 9%, 4%. So something is shifting. And I think we need to be looking at how providers then shift to meet that need in a more timely way. Otherwise, we will continue to see the issues that Rebecca's just spoken about and that we highlight in the report today, with 30% of people waiting 3 months or longer to get mental health support. So that's the kind of the stark numbers, the reality that we're facing. What can we do about this is to platform where we're seeing innovative models that are helping to address this. This idea of a 10-minute appointment with your GP or an hour and a half in secondary care mental health services, that's not what people need. That's what not the data is showing us. So we need to be looking at what we're seeing out there through our inspections, through our Mental Health Act review activity, through the system-wide work that Chris and Tolly have both spoken about, to look at what is working for people who need support, where do they need it, who do they need it from. And we can do that partly through the assessment framework consultation, if we get that sort of information back saying, this is what we need to be looking at as a system, and that will then feed into, and we're already beginning some conversations around this, but that will then feed into thinking about what should the workforce look like to prevent these difficulties in the future. Thank you.
Thanks, John.
Just in a sort of broader sense of how we're joined up, there is a national quality board that has previously been almost exclusively focused on health services. It is in the future going to be a focus on both health and care. And CQC is going to play a major part in that, and at least for the time being, I am co-chairing that with the chair of NHS England, Penny Dash. So we're getting going on that. We've got a big agenda there. We want a new quality strategy, first for the health, but also for social care. So there's a lot to be done, and CQC will be playing a major part in that.
Thank you. There's one last, sorry, the lady behind you was just ahead. I'm just conscious of time, but...
Thank you. I'm Steph Downey. I'm the DAS in Gateshead and really enjoyed the session this morning. Just thinking about the shift from hospital to community, people need places to live, and certainly for both older people and adults with learning disabilities, one of the biggest barriers we have is access to specialist and supported accommodation. And just wondering from an influencing point of view, appreciating that's not an area that you regulate, is there anything that CQC is thinking about or able to influence around housing, the building, and sort of the national policy and how that's supporting the delivery of accommodation and care?
Chris, do you want to...
I'm in Gateshead on Monday, actually, so perhaps we can have a look at some good examples. We've already had discussions with colleagues in Department of Health and Social Care about their emerging thoughts about strategy, and we've placed supported housing at the very forefront of those discussions, and similarly conversations with MHCLG, clearly, because that overlaps. One of the biggest increases in registered care providers is in supported living. So this is an issue, again, not just for older people, but people with working age adults with a disability. We're really clear that makes a huge difference to people's lives. We've seen that in the local authority assessments. Again, mixed picture in terms of the extent to which adult care departments work with housing. And just because a council's a unitary authority doesn't mean that those relationships are any different. I think local government reorganisation provides an opportunity. Perhaps the biggest single opportunity for adult social care would be around the join up of housing. I think a regalvanised supported housing strategy that would need to be cross-governmental is absolutely something we'd be really keen to lobby for and influence on, and really keen to see examples around where that's working, and we can take that forward. Totally agree.
One last quick question, if that's okay. Yeah.
Thank you. James Cregan from the Care Association Alliance and West Yorkshire and Humber Care Association. Firstly, Chris, thanks. You did come up to Leeds and you met with a group of us, and I hope we were useful to you. But I just wanted to, as an organisation, across nationally, we support independent, private and BCSC social care providers, mainly small and medium-sized providers. And just on the inequity and issues around, that's not just about people who use services, it's about people who work within them. And I think it's really important that we acknowledge that the vast amount of provision is done in the independent, private and VCSC sector, but we are not treated in the same way as our statutory colleagues. And that's not just about pay and conditions, all that is really important. It's also about respect and esteem. You know, I think it's really important from a CQC perspective that they understand that is that massive inequity across our communities, because the people who work in social care live in their local communities and spend their money in their local communities. So economically, it makes a lot of sense to actually be able to reward our staff. But I think the respect and esteem is a real issue for me. Our registered managers are often not treated as registered professionals, and the difference how our registered managers and registered professionals are treated, if you look at education and then look at social care, it's completely different, and I think we really need to address that balance quite quickly. Otherwise, the workforce at senior levels is going to be more decimated than at lower levels. Thank you.
Chris, do you want to...
Well, I'd absolutely echo that, and I think, you know, one of the hardest jobs in health and social care is being a registered manager of a care provider in terms of the risks and challenges you're facing. So I'd absolutely echo all that, and that needs to be part of the work, particularly around the 10-year plan, is, you know, what is the role and status of care providers within neighbourhood working? For most people with, for example, perhaps more complex needs, it's that interaction with the care provider which will be the most intense and regular interaction they will have. It's really important that they've all got a seat around the table in terms of making decisions. within that care workforce too, we know it's one of the most diverse care workforces, one of the diverse workforces across any sector, particularly in terms of race and, of course, gender. So inherent undervaluing of a care workforce is also a gender and race issue, and it's important that we see it through those lenses in terms of the esteem and the reward and recognition, both financially and non-financially, that the care sector secures.
Thanks. So, thank you very much for your questions and honest reflections on the report. Before I hand over to Mike to give his closing remarks, I just wanted to say thank you to many members of the audience who've helped us shape this year's State of Care. And as always, your contributions, your support, your understanding, and many of the pieces of work that we've delivered together are part of what goes into State of Care, as well as to colleagues, many listening online who are inspectors and regulators. This is their work that goes into the report that you see today. So with that, I'll hand over to Mike just to offer some closing remarks. I remind you, if you can, next door there will be refreshments and table numbers waiting for you in the next part of the debate. Thanks.
So you'll be pleased to hear that I'm not going to try and summarise every single question that's been asked this morning, but I hope you found the summary of the report valuable, and I hope you will go away and read more of the detail behind that, which you can have downloaded the QR code. I suppose on the positive side, I haven't heard anybody saying that we've got it completely wrong. So that is reassuring that there was a lot of emphasis that our comments about fragmentation, about the strain, about increasing demand are all very much agreed with, I think. I've also heard a lot of support for what's in the 10-year plan about the shift to community. We all know how difficult that's going to be, particularly as we haven't suddenly got a vast extra sum of money to put into the community, as Tolly was saying, in order then to be able to subsequently take money out of other sectors, particularly hospitals. I think we've also heard the breadth of what it is we as CQC cover, because you are also covering those areas. We heard powerful points about inequalities, which is very important to us. We've heard about carers, we've heard about learning disability and autism, challenging behaviour. We've a really good cross-section, and of course from primary care and from ADAS, etc. So it's really good that we've got that debate going. We hope you will continue this debate in the table sessions coming up. And I just wanted to say one thing. There was one question about will we continue to speak truth to power? Yes. That's a one-word answer to that one. We will. But then I'd just like to say thanks, first of all, to all of you for being here, because it really does matter to get your feedback. I want to say thanks to my colleagues. You've already been able to see that we've got wonderful chief inspectors. I'm very sorry again that Bola isn't here. But also thanks to Chris, you and your team for putting this on, and for all the work actually that goes into making State of Care. It doesn't write itself. Let's just put it that way. And then I'd also finally like to thank my non-executive director colleagues that we've got at least 4 of them in the room, and they have been providing support through a difficult time, and the support to me as much as to anybody, so thanks to them as well. But thank you to everybody.